Hi, it's Tim from ChiroUp, and I wanted to give you a quick review of Maigne syndrome and cluneal neuropathy because these conditions are implicated in up to 40% of lower back pain. Regarding the anatomy, the dorsal ramus or posterior ramus goes backwards and supplies the muscles in the skin of the back. In the thoracolumbar region, this dorsal ramus comes down through the thoracolumbar fascia and emerges as the cluneal nerves, which innervate the iliac crest and buttock. Potential sites of irritation for this include at the thoracolumbar junction. If that happens, it's called Maigne syndrome, or as these nerves emerge through the osteofibrous tunnels over the iliac crest. If the irritation occurs there, that's called cluneal nerve entrapment or neuropathy. These nerves emerge through a thoracolumbar fascia, and they can often be traction, stretched, or irritated at that region. Regardless of where the nerve is irritated, it causes a lower back symptom that looks very much like mechanical back pain or sacroiliac joint dysfunction, with pain in the lower back radiating toward the buttock and sacroiliac region, sometimes moving upward to resemble a kidney issue or radiating downward, even into the groin. The reason this is so common is because this is a biomechanical transition area, that the frontal orientation of the thoracic facets combines with the sagittal orientation of the lumbar facets and produces stretch. Not only when we're working, but when we're sitting in slouched postures or standing in slouched postures, but it's not always flexion. Degeneration is a common trigger for Maigne syndrome, and so extension is an issue as well. These patients are going to report pain after they're walking for prolonged periods of time, arising from a sitting position, rolling in bed, squatting, bending, and twisting. One of the challenges to this problem is that the area of symptoms is removed from the area of the origin of the complaints. So one thing that we want to do, like any neuropathy, is poke on the nerve. The nerves emerge through these osteofibrous tunnels, usually about 3 to 4 centimeters from midline, and again 7 to 8 centimeters from midline. The other thing that we'll poke on is the emergence at the dorsal root. So a PA shear test may be positive. Pinching the skin over the top of the area may demonstrate hypersensitivity. Slump test can produce some discomfort if the patient doesn't like flexion, and Sphinx test is going to be provocative if there is a problem with extension, especially if there's some degeneration in the area. Motion palpation can tell us is there some hypomobility or hypermobility in the area, but just because we feel discomfort in the region doesn't mean that the joint is necessarily stuck. One of the key contributors to Maigne syndrome is instability. So patients who are young and very flexible with a straight leg raise that's excessive, and they have a positive PA shear test, a highly useful test which entails pushing on the thoracolumbar junction, then having the patient lift their legs and pushing on it again. If the pain diminishes when they lift their legs and engage the multifidus and deep spinal stabilizers, the patient has told us they probably have some instability and would appreciate stability exercise. The other thing that we want to check is the breathing pattern, that too many times patients are breathing from their upper chest as opposed to from their belly, and so that places stress on that thoracolumbar junction. We can take radiographs. They could be negative. They may show something, but rarely does that correlate with the patient's symptoms unless there's severe degeneration at the thoracolumbar junction. Regarding management, we'll reduce inflammation with ice and anti-inflammatory modalities or medications, but more importantly, we want to restore biomechanical function to the area, to the joints and nerves. So stripping out the quadratus lumborum and lumbar rectors as well as the psoas is helpful. We're also going to release the thoracolumbar fascia. Remember that posterior ramus emerges from the thoracolumbar junction underneath the fascia, emerging through the fascia. So anytime there's tension in that fascia, it's going to tension the nerve, creating ischemia and hyperexcitability. A great way to release that fascia is having the patient in a side-lying position, trapping their leg, and then stripping through that fascia as we stretch. We can also incorporate a contract-relax stretch with that as well. Some practitioners choose to use shockwave therapy or cupping to help stimulate blood flow to the fascia. And we know that manipulation and mobilization are helpful. In fact, Dr. Maigne himself identified painful minor intervertebral dysfunction as a key component. But once again, don't forget it's not always hypomobility which needs manipulation and mobilization, stretching, and foam rollers, but some patients are hypermobile, and for them, stability is going to be the key with a focus on breathing retraining. Exercises that may be appropriate depending on the diagnosis or the origin would be stretching the psoas, a bretzel stretch for the thoracolumbar fascia, a plank to incorporate stability, and nerve flossing of the cluneal nerve. Pelvic tilt exercises have shown benefits starting on the back, transitioning into standing and progressively more difficult versions, and a foam roller would help, especially if there's a hypomobility issue. Most importantly, we want to make sure that the patient's diaphragm is functioning, so we put a hand on their belly, a hand on their chest, and teach them to move just the hand on their belly. And when they breathe, they should expand their lower rib cage by pushing out into their hands. If you'd like to review any of the assessments or management, simply navigate to ChiroUp.com if you're a subscriber. If not, start a trial today. Go to Condition References, select Maigne Syndrome, and then you can check out the evaluations, the management, and the exercises for this or 100 other diagnoses. If you'd like to review the best practices regarding the etiology, the clinical presentation, the radiology findings, diagnostics, or the references, they're all available. Hope you'll visit our website today and get started. Thanks for watching.